Hello dear friends, today I will talk about how to write drug formularies. This drug formularies is not only important for the exam point of view, where if you ask to write short note on any drugs like atropine or spironolactone, hydrochlorothiazide or any other drugs, penicillins, uh, so short note write according to the formulary you write in the your logbook in undergraduate level. And this is not limited to only this purpose. This formulary this formulary is a booklet form of a booklet form where therapeutic drug class, similar drugs, mechanism action, indication or therapeutic usage, adverse effect, contraindication, drug interactions, rationale of combinations, all things are included. Even in some countries like in Britain, their dosage form and brand name, cost are also included. Like these things are not included in Indian formulary, means this booklet is very effective for the doctors, for the prescribers to prescribe particular drug in a particular condition. So after basic level, first and second level, when you practice in clinics or hospitals, these formularies will also be helpful there. So please give importance to these formularies. And in pharmacology practical, you are basically asked or given a particular drug in different uh, dosage form. So what there is asked, that classify the write the therapeutic group, adverse effect or mechanism action or contraindication. Same thing, same patterns question are asked in the pharmacology practical besides other questions. So this is very important chapter. Drug formulary. Formularies, to write these formularies, there is a pattern that we should follow. How to write that? So drug formulary, I mentioned the significance and brief introduction what it is, and you please follow the if you like, please follow KD Tirupati, Essentials of Pharmacology, whichever uh, edition is authorized in your territory. I am taking the reference from 8th edition, South Asia publication. So drug formularies, and even this contains informative appendices as well, these drug formularies, and it will be easier for the prescriber to prescribe a particular drug in particular conditions. So in drug formulary what happens is that first you should write generic name, generic name generic name of drug. What does it mean? I hope you know, but I want to take back uh, shortly, that for a particular drug there are three names of a particular drugs, three names that include. First is chemical name. Name means the chemically what the drug is. Most of the time they are like complex organic or inorganic molecules, and so that will be your chemical name. What chemical name it is? That is chemical name. Now second is non proprietary name. Non proprietary name. Non proprietary name, this name you can call also the generic name. Generic name. Generic name. And there will be proprietary name. Proprietary name, these are the name given by manufacturer or manufacturers according to the this name. For a single drug, this name differ according to the different manufacturer or manufacturers. Now I will focusing on this non proprietary name. This non proprietary or generic name, these are the name adopted by scientific uh, let's say scientific body, scientific authority or scientific body. These names are adopted by them. So why this name is preferred? Even in prescription writing, you should write this non proprietary name, or even you prescribing the drug. Once you prescribe drug in clinic or hospital, it is preferred to write non proprietary name, because if you prescribe or write this proprietary name, first thing that you are going to market of certain manufacturers. This gives like biasness, and as a medical person we should not bias. We should bias only in quality, like whichever is better quality drug and better tolerated in a particular patient, that drug should be prescribed by a medical practitioner. So that, and another reason is that to bring the uniformity, this name non proprietary name, I mentioned this name differ according to manufacturers. So this name in most of the time maintains uniformity. Like propranolol, you call in Nepal, India, Britain, USA, propranolol if you call, all will understand. And if you mention the proprietary name of the propranolol, it will differ according to country or even manufacturer to manufacturer. So we should write this non proprietary name, and there are very other significance and debate too, that we should write this name non proprietary or proprietary, because if you write like non proprietary name, the pharmacist uh, may promote certain brand of the drug that may not be good in quality. So there are many debate in that cases. However, most of the time these non proprietary name or generic name is preferred while prescribing a drug, because these are adopted by the scientific body. So what we should write here in generic name, this non proprietary name. Generic name of a drug, like let's suppose I will write here spironolactone. Spironolactone. I will be taking example of this spironolactone while uh, describing how to write this formularies. Spironolactone, so that it will be easier to understand for you. Spironolactone. Then there will be next will be number 2, similar drug. Similar drug. Here you should be most careful. This similar drug you should write only if the if uh, those drugs include same mechanism of action. If the mechanism of action differ, you cannot write in the similar drug. So similar drug, what you write here, like for spironolactone it is eplerenone. Now this is the spironolactone is the diuretic, weak or adjunctive diuretic, you know. These diuretics, there are many other diuretics like thiazides, loop diuretics, uh, renal epithelium sodium channel blocker. So those all are the diuretics, and you are not supposed to write those names because these and this drug only shows similar mechanism of action. So write this eplerenone here. Now next will be therapeutic group. Therapeutic group or class. Here again you should be careful while writing this. Let's suppose this eplerenone is the uh, finest, like hierarchy wise, it is the aldosterone antagonist. By mechanism of action, it is aldosterone antagonist. Then it fall under potassium sparing diuretic. And this will fall under weak or adjunctive diuretic, or let's say diuretic. Diuretic. So therapeutic group should be written in closest hierarchy. Closest hierarchy is the aldosterone antagonist, because this K plus sparing, if you write K plus sparing, this also include uh, renal epithelial sodium channel blocker. This also include there that. Now if you write this only this K plus sparing diuretic, this may signify these drugs also, like amiloride. Here will be amiloride and triamterene. So closest hierarchy should be written in the therapeutic group, but here you can be a bit liberal, like if you don't know the closest hierarchy, then move up till the broad field. Broad name means something is better than nothing. while writing, this is only while writing for writing purpose in exams or in while asking in viva. So what here should be written? Aldosterone, aldosterone antagonist, antagonist, gonist. Then here again few confusion may arise, like let's suppose uh, you are given cefixime, you are given cefixime, cefixime, cefixime while writing therapeutic group, while writing therapeutic group, um, this is the third generation, third generation cephalosporin. So here you should write cefixime, uh, cefixime third generation cephalosporin, or even you if you don't know the generation, at least you should know the cephalosporin, cephalosporin. Like I mention here, confusion where can arise, like natural alkaloids, natural alkaloids, natural alkaloids, it is the both cholinergic and anticholinergic, this include, like in cholinergic, cholinergic it include palm, pilocarpine, ericulin, muscarine, and in anticholinergic these natural alkaloids will include atropine, atropine and hyoscine, atropine and hyoscine. Then in therapeutic group, if you write natural alkaloids, it will not signify better, it not will signify the therapeutic group better, that what type of this drug is, what type of this drug is. So in that case, you should also mention in bracket the broad name, like this is natural alkaloid, you write here and then in bracket signify that this is anticholinergic, this is cholinergic. So in this way you have to, like this group or this group should signify what particular type of this drug is. It gives sense, not confusing. It should not be confusing, like here natural alkaloids, both are natural alkaloids. If you write natural alkaloids only, it will be confusing. So if one name is not signifying the closest hierarchy, not signifying the particular type or group, then add the bracket broad name also. So this is about the therapeutic group. Again in therapeutic group, like if you write amoxicillin, amoxicillin or ampicillin, these are the aminopenicillins and these will follow the extended spectrum penicillin. So in that case, if you write aminopenicillin, okay, it will signify that is penicillin and type is the amino type. Or if you don't know that, at least you should not know, write extended spectrum penicillin, or even you don't know that, at least you should write penicillin, but please prefer to write the closest hierarchy. So now there will be, then will be the mechanism of action, mechanism of action. This mechanism of action is very important. For that I will draw here a photo, very, though I am not good in drawing, I will draw so that it will be easier to understand for you. Like this, let us suppose this is the lumen, lumen of late DC, distal convoluted tubule, and cortical collecting duct, cortical collecting duct, and this is the principal cells, principal cells, principal cell of that lining epithelium of this DCT and CCD. So this is the lumen. This will be the basal membrane and lateral. So basolateral membrane. So here what happens is that there is called in this cell there is a receptor called there is a receptor called mineralocorticoid receptor MR, mineralocorticoid receptor, and here is the, let's suppose this is aldosterone, this is aldosterone, and this group of the drug spironolactone aldosterone antagonist type of drug have similar structure like this aldosterone. This is aldosterone molecule, aldosterone aldosterone molecule, and here will be the similar type of the, let's say this is eplerenone or spironolactone, lactone. So here due to the similar structure, what happens is that both will compete for the binding. If this spironolactone is present, it will replace the binding of the aldosterone and hinder the reverse the all mechanism of this aldosterone. How? Let's suppose if this uh, bound by spironolactone, then it will be like this. Uh, this is spironolactone mineralocorticoid receptor complex. Spironolactone mineralocorticoid receptor complex. This complex now will migrate to the nucleus. Nucleus, here you know in nucleus there is the DNA. So there will be this complex will bind at particular space, like let's say hormone response element, in this case hormone response element. So for mechanism action to proceed, this aldosterone should bind here, because if this bound, this mechanism will stop here. So here will be the binding of the, first talk about the normal then abnormal. Let's suppose it is bound by the aldosterone mineralocorticoid receptor complex. This will migrate to this nucleus, and here in nucleus what happens is that uh, this complex hormone response element, something called as the hormone response element for a particular hormone, there will be the space for this DNA molecule. There it will bind, and what it will do, it will make RNA, messenger RNA transcription, that is transcription of is happening here. Now this mRNA molecule will again translocated out from the nucleus, and it will come to cytoplasm. This mRNA, mRNA molecule. Now this mRNA what will do, it will by translation mechanism it will produces aldosterone induced proteins. That proteins will include here, it will form sodium potassium channel protein, and sodium potassium ATPase enzyme. These will be formed here, and what this sodium potassium pump will do, pump to potassium inside and form 3 sodium outside. 3 sodium outside. I have talked in detail this sodium potassium form in the uh, like membrane potential lecture. So you can see there the detailed descriptions you can see from that videos. And for action of these it will lead for action of this it will lead sodium potassium ATPases. Sodium potassium ATPases, it is a enzyme protein ATPases, and it will break ATP into ADP and inorganic phosphate. So this AIP will include also this sodium potassium ATPase and this channel protein. Here will be the inactive sodium channel that will draw the sodium inside by facilitated mechanism inside. So this is renal epithelial sodium channel, inactive channel. This is inactive channel, and so this AIP will also include this inactive channel. It will form inactive channel. Here is sodium in the lumen, and one more channel protein it will form is that Rom K, means renal outer medullary potassium channel. This channel what will do, through this channel facilitate diffusion of the potassium will occur from inside cell, luminal cell to the lumen, This is the basic mechanism, and what this will do also, AIP also include, like this AIP will induce the uh, energy generation by mitochondria, ATP formation, increase ATP formation by mitochondria, because here is energy needed. So all this mechanism is for reabsorption of the sodium from the lumen of lead DCT and CCD, and expulsion of the potassium from the principal cell to the lumen, and how this happen. So this is primary active transport mechanism, and this will be secondary, let us suppose this is secondary active transport mechanism. So primary active transport mechanism what will do, it will create inside less sodium inside. So from here will be higher concentration, here will be lower concentration, the sodium will flow inside, and what this will do, potassium pumping is inside, concentration of the potassium will increase, and that will lead to the efflux of the potassium through this channel, So and if there is the entry of the sodium, water always flow the sodium. So here water will also osmosis here will be the osmosis of the water inside the cells and interstitium, and then blood vessels means these are retaining sodium and water. Remember here chloride will not be influxed through by this sodium channel. So now this is the normal mechanism of the yellow stone. Now what will do this spironolactone? This spironolactone bind here and replace the aldosterone. Replace then this if bind with the spironolactone, this will not induce the hormone dispersion element, and there will not be the transcription, translation, no formation of the AIPs. That means all mechanism will be stopped or reversed for the aldosterone action. So this is the mechanism of action of the spironolactone. You can write in words. It is already too much time consumed for explaining this mechanism. So why I mention this? If you know the mechanism, the usage and adverse effect, even contraindication, will not be big deal for you. I will relate how to write this. And here, this inact channel, one more mechanism accidentally you found here is that this inact channel is blocked by this inact channel is blocked by, let us suppose this is blocked by this spironolactone. This is blocked by renal epithelial sodium channel blockers. Mechanism of action will lie here. This that is, it include amiloride and triamterene. So this is the mechanism of action, and this if this will be blocked, no entry of the sodium, no entry of the water, no retention of the salt and water, no efflux of the potassium, and potassium will spared. In both cases, potassium is sparing inside the cell and in interstitium in blood. So the name is K plus sparing, potassium sparing is also given for these two categories of the drugs by the mechanism of action. So now I will write the indications. Indications are therapeutic usage. For this indication, while writing formulary, maximum you write 4 or 5 indications only. Beyond that, it is not good to write even in writing purpose. So maximum, then if you write limited usage, you have to write specific and important usage at the top. That is, in chronological order you should write this therapeutic usage. It is what is most specific and important use, write first, then less, then less, then less. So write in the chronological orders. So here what will be the usage or indications? First is since this is weak or adjunctive diuretic, it is not generally used alone. It is used to counteract hypokalemia caused by thiazides and loop diuretics. I have talked how this is caused, hypokalemia and hypokalemia by thiazides and loop diuretics, in the diuretic lecture. So you can refer that. Diuretic means why hypokalemia is there by these drugs, and what these drugs are doing, sparing the potassium if it spares potassium, there will be hyperkalemia, and hyperkalemia, then in case of the hypokalemia, this can be given to counteract the loss of the potassium, and this is seen from mechanism of action. As I mentioned earlier, that if you know the mechanism of action, you can write usage and adverse effect, even contraindication too. So first and foremost use is this. So concurrently used in with thiazides and loop diuretics to counteract the hypokalemia. Then there will be next use, or even if you by other mechanism there is hypokalemia occurring, in that cases by seeing other parameters, you can use this spironolactone or K plus sparing diuretics too. Now then what happens is that here is the again use of the edema. In case of the edema, especially cirrhotic and nephrotic edema. These drugs are preferred. Edema, you know, this is the accumulation of the excess fluid in the interstitium, or interstitium, yes, in the interstitium of the body tissue cells. So if there is cirrhosis, there will be ascites, that is edema of the peritoneal cavity. Ascites in nephrotic edema, like if there is nephrotic syndrome, what happens is there will be the excess loss of the albumin. Albumin is the osmotically active particle. Since that loss is occurring, body's defense mechanism what will do, it will try to retain more. So this, if albumin is losing, there will be loss of the fluid also, since that is osmotically active particle. Then body what will do, try to retain the salt in excess, and that salt means sodium will again retain the water, and that water will dilute the plasma fluid, and if there is the dilution, hydrostatic pressure will be increased, and that hydrostatic pressure in the capillaries if increased, that will exudate out in the interstitium and causing the edema. Detailed mechanism of edema I will talk in the pathology. So in that cases, this spironolactone can be used. Spironolactone or amiloride can be used. Then next will be hypertension. In hypertension, specifically resistant hypertension, in case of the in hypertension normally used concurrently with this thiazides or loop diuretics, or in case of resistant hypertension that is not reversed by the thiazides, not reversed by loop diuretics or thiazides alone. So in that cases this can be used there too. Now the fourth use is the hypertension, like okay, the important use again will be the primary hyperaldosteronism. Hyperaldosteronism, there can be also this used. Why? If there is a hyperaldosterone, secretion of the aldosterone in excess, this mechanism will augmented, and there will be increased retention of sodium and increased sparing of the potassium. So to reduce that, this aldosterone antagonist can be used to antagonize the action of the excess aldosterone. So in that cases you can use all these are coming from the mechanism of action. So these are the important uses of this spironolactone. So indication or therapeutic use, write 4 or 5 maximum and from the chronological order. Now I will talk about the adverse effect. Adverse effect. We are learning about the how to write drug formularies. So what again you this adverse effect, write 4 or 5 maximum and again in chronological order, which is most significant, most serious, write first then lower. So here what is happening, sparing of the potassium. So this sparing will lead to the hyperkalemia. So hyperkalemia will be the most serious problem. Hyperkalemia. Hyperkalemia. This is most serious problem. Most serious problem. If you know this hyperkalemia, even a small increase in the calcium level will lead to the severe disrupted physiology, STD states. Let us say internal environment, this will disrupt. So this will be monitored closely. Then there will be frequent again significant, this will be the like sexual related, like in case of male, what will happen there, it will cause impotence, that is erectile dysfunction, loss of libido, and gynecomastia. Mechanism is that, briefly, this will this spironolactone will increase the clearance of the renal clearance of the testosterone. So as soon as testosterone is released, it should do the male sexual activity, enhance male sexual activity, but if the clearance is increased, that will not do significantly that. And one other mechanism is that this spironolactone will convert testosterone to the estrogen. If you know the endocrine proper, that the end product of this spironolactone, testosterone is also the estrogen. If there is estrogen conversion excess, then the side effect of estrogen will be seen in the male, like gynecomastia and loss of libido. So in female, what will happen there? It will cause breast tenderness, and menstrual irregularities. Menstrual irregularities, this will be caused. Not always this side effect will not always occur, but this is significant, so I write at top. This is significant, so I write at first. Thus most frequently associated symptoms or side effects are like drowsiness, ataxia, ataxia, there will be mental confusion, mental confusion, mental confusion, epigastric distress, epigastric distress. This is frequent adverse event, frequent side effects, frequent side effects. This is not so much frequent, this uh, point second. How I write, however, I write at on top because this is significant adverse effect. If there is happening in particular patient, you should replace these drugs with other drugs. And for replacement, in case of eplerenone, in case of eplerenone, this is the newer congener. This eplerenone is free of this sexual related disturbances adverse effect. So in that case you can replace spironolactone with this eplerenone. So this is the how to write adverse effect. Adverse effect. Now there will be the contraindication and then drug interaction. I will drop here. We are at point 7, I think, yes, 7. So contraindication. What is the contraindication of this spironolactone? And in case of other drugs, you should write then contraindication. Contraindication. So contraindication, it is concurrent use of AC inhibitors, and ARBs, aldosterone receptor blockers, ARBs, is contraindicated with spironolactone use. Concurrent use of spironolactone and these drugs will be contraindicated because these AC inhibitors and ARBs ultimately going to block the aldosterone action. How? So you can refer to the diuretic lecture I have mentioned there, or like let us suppose I have mentioned in lecture, yes, renin-angiotensin aldosterone mechanism. There I have explained how these drugs will decrease the effect of this aldosterone, and this is also decreasing the action of aldosterone. So both will combinedly can cause severe hyperkalemia, severe hyperkalemia. So this is concurrent use is contraindicated, and this is the frequently asked MCQ and viva question. Frequently asked MCQ and viva questions. Remember this point, contraindication. Then there will be drug interaction. You should write drug interactions if there is any drug interaction. Then rationale of combination. So drug interaction. What does it mean? It means it is the interaction between two or more drugs if given concurrently. So in that case, how these concurrent drugs should be applied, and that is defined by this drug interaction. So in case of this aldosterone antagonist, that is spironolactone, this contraindication can also be included in this drug interaction, like these AC inhibitors and ARBs should not be given concurrently with spironolactone because spironolactone and these drugs both are causing the hyperkalemia. If given concurrently, hyperkalemia will become very severe. So drug interaction, same thing can also be written here. Contraindication means that cannot be applied. So in this case, drug like ARBs, AC inhibitor, AC inhibitors and AC inhibitors and ARBs are not given concurrently, given concurrently, that is simultaneously. Why? The reason I already mentioned, due to severe hyperkalemia. Now one another drug interaction will occur in, like, this aldosterone should not be given during during patient on potassium supplement. If the patient is having potassium supplement means there is already enough potassium in the body, and if given this spironolactone, this will further lead to the increased amount like increased concentration of the potassium inside the body. So in that case, this drug is better to avoid. Next is that, like, in case of digoxin toxicity. If given concurrently this spironolactone during digoxin therapy, what will happen? This spironolactone increase plasma concentration of digoxin and cause may precipitate digoxin toxicity. So in that case, if digoxin is mandatory, that should be used in that patient, then this dose of this digoxin should be reduced. Digoxin toxicity. And one more interaction will occur while aspirin. This aspirin, what does it do? Aspirin decrease the tubular secretion of spironolactone. Hence, it is better to avoid during aspirin therapy, because what happens is that if spironolactone stay in the body for long time in increased concentration, higher concentration, this action again, the side effect will be aggravated. So in that cases also spironolactone is better to avoid. Spironolactone is better to avoid during aspirin therapy. Or aspirin therapy should be stopped while this spironolactone therapy is continued, or in very reduced dose. This spironolactone in very reduced dose it can be used, so that the side effects will not aggravate so much. Aspirin during aspirin therapy. therapy. So these are the drug interactions of this spironolactone, and remember the contraindication. This is very important point for the MCQ and Viva. And now in case of contraindication, if there is any precaution for any drug, there is any precaution, you can also add here the precautions. Like in case of aminoglycosides, there are various precautions, like it should not be used in their pregnancy, during pregnancy, and older age, or nephrotoxic, being nephrotoxic and hepatotoxic, like hepatic failure and kidney failure cases, those should be minimized or should not be used. So precautions can also be added here. Now last is the rationale of combination. I will draw this rationale of combination. Means, what is the effect if two drugs given concurrently? What is its significance? Like rationale of combination. Rationale of combination means here, this spironolactone I earlier also mentioned, this spironolactone is given supplement, given with the thiazides or loop diuretics, and given with thiazides, along with thiazides or loop diuretics. So rationale of combination, diuretics. Rationale of combination will be diuretics. Rationale of combination will be, first is compensate the potassium loss, compensate hypokalemia. That means these loop diuretics and thiazides will cause hypokalemia, and this is causing hyperkalemia. So calcium level will be, potassium level will be balanced, compensate hypokalemia. And next is potentiate this spironolactone will potentiate these diuretics. I also mentioned in resistance cases of hypertension, this diuretics is added in these loop diuretics or thiazides. So synergistic effect, potentiate loop diuretics or thiazides, that is synergistic effect. For this reason, this spironolactone is given along with the thiazides or loop diuretics. And in other cases, there may also be the useful significance of the combination of two or more drugs. Like in case of the cotrimoxazole, what happens there? Trimethoprim and sulfamethoxazole given concurrently, combinedly, in a fixed dose ratio. So significance will be, first synergistic action, then the individual drug is the trimethoprim or sulfamethoxazole is the basically bacteriostatic, and in combination they will become bactericidal, that is more effective, and the dose will be reduced. Individual drug if given individually, dose in that should be given in higher dosage, but combinedly the dose should be decreased, dose will be decreased, and that will decrease the severity of the adverse or side effects. So for the benefits, those drugs are combined, though that will be the rationale of combination. So this video became typically long. I am sorry for that, but please remember, I also side by side talked about the examples, and so that it would be easier to understand for you. Thank you for watching.